Hi, welcome to the second video of this course. We'll be talking about selective tissue tension today. In brief and in principle, they'll get more detail on this as the course progresses, naturally. Um, Selective tissue tension testing is a process of examination. It's also called the scan exam. That was designed by James Cyriax, a physical medicine physician in England, and a major player in the early days of manual therapy. This was in the 50s, 60s, mainly in those 2 decades. I had the pleasure of being taught by him, both at school and at his clinic, and it's quite an experience. The whole thing is based on anatomy and pathology. You know the anatomy, you know what the particular structure is supposed to do, and you know how the pathology affects it. So the principle of all this examination is to, as much as possible, isolate that structure and then stress it. For example, you look at the joint itself, the capsule, the ligaments around the joint, and the general joint environment with passive movements. And as this is a passive movement, it tends to isolate it from the contractile tissues to a point. And this is the thing with all of this, it's always to a point. Now, when Cyriax taught this, it was very black and white. Isometric tests the contractile tissues. Um, Passive movement test tested the joint. Stress tested the ligaments and so on. So each one, in the way it was taught, was very, very much black and white. In reality, it doesn't quite work that simply. For example, you can have a highly inflamed joint, and if you do the resisted test in a neutral position for the joint, in the least packed position where the joint is under least stress, if it's very inflamed, that contractor can still compress the joint and cause pain. So it's not as simple as I'm going to make it out, basically. For principle's sake, we'll approximate it and make it simple. But remember that it is grey rather than black and white. So you do active movements and you're looking at the quality of the movement. Is there a painful arc? What's the range look like? Is there pain at the end of the range? And how willing are they to move through that range? It'll give you a better idea of how acute this is before you start mauling them with your passive movements. But it also produces information that the passive movement doesn't. The passive range can't tell you about quality of movement. It can't tell you about painful arcs. Not really, anyway. So all of this comes into it, but you've got to remember that the active movement is testing all tissues, both the contractile tissues and the inert tissues. The passive movement is generally done at the end of the active range. You don't do a passive movement all the way through range, but you just add it on with a bit of overpressure at the end of the active range. And the overpressure is done into pain-free and painful ranges. Now you'll hear a lot of people say you shouldn't overpress into pain, but it doesn't make any sense. If you don't overpress into pain, you will never feel an abnormal end feel. And the only thing you can say about it is that range is painful and not know what might be causing that pain. You will never feel a spasm end feel, for example. You just won't, because that has to be associated um, with pain. So it's important that the, the overpressure is done in all ranges. You assess the end feel, you look at the range of motion, which should be more than the active range under normal circumstances, simply because you're taking the muscle out of it, at least in part, and you're now moving much more towards the inert tissues. So we can say that the active range tests all sorts of stuff, the contractile, non-contractile tissues. The passive movement tests the non-contractile tissues for the most part, although remember that you are stretching contractile tissues, which is, as I say, is a complicating factor. We then come to the resisted or the contractile tests. Now, Cyriax considered resisted tests to be contractile, and we'll talk about that first. These are isometric tests, so no movements are occurring, which in part reduces the effect on the joint structures. And so again, this is selecting out the joint and selecting in the contractile tissue. But there are exceptions. We talked about that a little bit earlier. Um, so here you're looking for pain and weakness, whether they are coming on at the same time. So painful inhibited weakness would suggest something like a grade 2 tear, possibly a fracture even. whereas pain-free weakness might suggest a grade 3 tear. Painful pain and no weakness would suggest a minimal or minor contractile lesion, but often with more severe stuff like true tendonitis, grade 2 tears, the pain will come on as the weakness comes on, so you have pain inhibition. We can then also look at the ligaments. I know we've tested the ligaments in part with the movements, but we haven't got a lot of information about the ligaments. So we'll talk about stress tests. So typically what you do is you have a ligament in mind, and you will then do movements that will first tighten it and then tauten it and then stress it. So in this, for an example, would be the medial collateral ligament of the knee. Generally, this is mostly tight in extension. You can tauten it by adding a valgus stress, and then by really stressing the valgus tissue, you now stress the ligament. You're looking for pain and stability, pain and instability. First one suggesting a grade 1, second one suggesting grade 2, and no pain and severe instability suggesting grade 3. Neurodynamic tests include straight leg raise, prone knee flexion, scapular retraction, neck flexion, the upper limb tension tests, and so on. And their adjunct tests. So for straight leg raising, for example, neck flexion and dorsiflexion of the ankle would be the adjunctive test. Lasag's test is another way of doing a straight leg raise, basically. So these tests are mobility, not just of the dura, but of the neura also. So depending on the symptoms you get when you do the test, you can talk about this being a dural test, or at least a dural positive or a neural positive. If you're getting neuropathic pain when you do a straight leg raise, for example, then the tissue that's causing that pain is neurological tissue, damage to the nerve root or the spinal nerve. While if this is somatic pain, you really can't argue for it being neurological simply based on that test. So that's probably the dura. These neurodynamic tests are based on the constant length phenomena, which says the range of motion at one joint will be limited by another joint if a common tissue runs over them. So if you're doing a straight leg raise, which is hip flexion, you'll get a certain range of motion with the knee straight. You bend the knee and you get much more. So this is what the constant length phenomenon is. And then you have the hell does that say? Neurological testing. Sorry, the neurological test, dermatome-myotome reflex, is so called. It's not very precise language, but it's the one that's commonly used. So we look at the myotome by doing strength testing. We're mostly looking for fatigable weakness, which would suggest axoplasmic flow problems, I believe. But there are other non-mechanical reasons why you may get fatigable weakness, but it would suggest a radiculopathy. I don't think you can say the same thing about peripheral neuropathies, because I don't know if diseases will have the same effect on fatigability as compression does. My guess is probably not. But we don't see enough neuropathies to be able to say one way or another. The dermatome test is obviously sensation, and light touch isn't running, just for this sake, light touch is not running your fingers down the arm. That's not light touch. It's a sensory stimulus to the skin. It's also very much a sensory stimulus to the hair follicles, and these tend to be very robust, so it's a poor way of testing. Light touch should be done best with a monofilament if you're going to do light touch. Failing that, you can use a corner of a tissue paper and dab it on there rather than scrape it along, because again you're going to stimulate the hair cells more, but a monofilament is best. Pinprick is fine. You're testing different tracks, but we're not interested in the tracks now. We're interested in the nerve and nerve roots. And then finally reflexes. So we're looking for hyporeflexia if we're looking at a radiculopathy. Now, reflex changes are probably the least noticeable sign. They're more difficult to pick up, and if you are picking up profound hyporeflexive problems, then almost certainly you've got a fairly severe problem on your hands. But the weakness and the sensory loss, if they're done properly, are easily picked up. The other reflexes, of course, are upper motor neuron reflexes. Hoffman's test on the fingertip, Babinski, Clonus, and so on. So we've got these other tests that we can do, as well as the deep tendon reflexes, looking for hyperreflexia. The specialized tests, or the special tests, if you like, Phelan's, Finkelstein's, there's dozens of them, are done when you have a particular pathology in mind, and these are maybe specific to some extent for these conditions. So these are not really routine tests, these are done for a particular purpose. The important thing here, of course, is analysing what you're finding. What's the distribution? Is it segmental distribution? Is it a plexopathy? Is it a peripheral neuropathy? So the distribution will help you with that. There are other factors as well. Neuropathy is much more likely to give you profound sensory and muscular loss than is a radiculopathy, simply because of the multiple segments innervating a muscle and a piece of skin. But this is what you're doing now. You're going to analyse all of this information from the selective tissue tension test and come up with a conclusion as far as a pathoanatomical diagnosis. Okay, we'll talk about strengths and weaknesses a bit later on. You'll learn much more about this during the classes, and we'll talk about it on the ensuing Zoom session, which will cover this video. I hope you enjoyed, and I will talk to you again soon. Bye-bye.